Thank you so much, moderator. As introduced, my name is Martin Mukama. I work as the Innovations Manager at CAMTech. CAMTech is the consortium for affordable medical technologies, and what we do in CAMTech is that we identify health challenges and then build appropriate technologies. And so today I'll be presenting about one of the technologies that we've designed and tested in the field called Protecting Infants Remotely by SMS. But the abstract I'm presenting is titled Impact of Protecting Infants Remotely by SMS on Neonatal Care in a District Hospital. And the district hospital we are referring to is Kagadi. So PRISMS combines clinical decision support and education, data collection, and then lastly quality improvement. And we'll see how it does those three items. And just to give you a background on PRISMS, we discovered that globally 2.5 million babies were dying in the first month of life. And most of those deaths were happening in the first week of life, with about 1 million happening on the first day and another 1 million happening in the next 6 days. And that's about the time when the babies are actually in the facility. But also most of these deaths actually happen in low and middle income countries like Uganda, that accounts for 90% of all global neonatal mortality. And in Uganda, for over a decade, neonatal mortality has actually not reduced. It still stands at 27 deaths per 1,000 live births. And in Uganda, most of the newborn care, if you visit facilities that are in remote settings, you'll find that most of the newborn care is actually being done by midwives and nurses that are not sufficiently trained to make clinical decisions for the sick newborns. And so the gap that we identified is that most of the midwives are actually very good at doing assessment. You take your baby, they can assess the baby very well, but the problem was with clinical decision making. And the reason we developed PRISMS was actually to guide the clinical decisions for those midwives that were caring for sick and at-risk newborns. And so PRISMS, first of all, uses the assessment findings that they feed in to generate a management plan. It also does continuous newborn care education, but as people use the technology, there is a lot of data that is collected that we use for quality improvement. And so we started designing this technology way back in 2014. We first tested it for feasibility in 2016, and the results were really amazing. They are the ones that really gave us a push to, keep working on the technology. And the publication from our feasibility and acceptability study is actually published. You can check it online, plus the additional results from that study. But this is the gist of my presentation. I'll be presenting about the impact of PRISMS in Kagadi Hospital. And so the methods that we used in Kagadi were, we first trained the health workers that were going to be involved in using the technology in what we call the Helping Babies Survive package, which includes helping babies breathe, essential care for every baby, and essential care for small babies. And then we also took them in how to use the PRISMS technology. And then we deployed the technology in the facility, and it's actually still running there. And then for the duration of the technology, we are conducting mentorships between 4 to 6 months. And the mentorships are actually being guided by the data that was being collected through the use of PRISMS. And these were the characteristics, the clinical characteristics of the babies that were assessed between that period, between October 2020 and July 2021. PRISMS was used in assessment of about 3,400 neonates, and NICU contributed about 56% of those babies. And the instance of hypothermia was 27%, and of the 27%, 91.2% of those babies were having a temperature that was below 3.35 0.5 degrees Celsius. The incidence of hypothermia in NICU was 42%, and of the 42%, 20.8% of those babies were having a temperature that was below 35.5 degrees Celsius. The babies that were unable to feed represented 1.2% in maternity and 64.5% in NICU. NICU is where most of the babies that are very sick are admitted to. And the babies that had a capillary fill of greater than 3 seconds were 0.1% in maternity and 9.9% in NICU. And the babies that presented with chest indrawing were 0.4% in maternity and 11.6% in NICU. But this is what was very interesting. So before the intervention was introduced in that facility, the mean in-facility neonatal mortality in NICU was 8%, with a confidence interval of 95%, with a 95% confidence interval that was between 3.1 to 12.9. But after deploying the technology, the in-facility neonatal mortality reduced to 3.4%. So most of the babies were actually being saved just by empowering the midwives that were managing the babies. And we can see that mortality between that period was between 2.3 to 4.5, and the p-value is right there. And that's the curve. The blue line represents the period before intervention. And you can see where the arrow is, the red arrow is pointing down, is when we introduced the intervention. But you can see after introducing prisons in that facility, neonatal mortality, in-facility neonatal mortality started dropping significantly. And the line graph that is in orange represents the time when prisons was being used. And you can see we never hit mortality above the period prior to introducing our intervention, which is very good. So we are having more and more babies actually being saved because of this intervention. And so we know that a combination of newborn care training, mentorship, and prisons deployment has the ability to actually reduce neonatal mortality. And we are currently actually working in 62 health facilities in Uganda, and we have adapted the technology to the newborn guidelines of Tanzania, and we'll be deploying the technology also in Tanzania. And so we recommend prisons for routine in-facility care for neonates. I want to acknowledge the people that have supported this intervention: the Ministry of ICT, NITAU, MAST, Bela Children's Foundation, ComTech, Doctors with Africa, QUAM, Sim for Life Project and Barra University, and CHI, which is Clinton Health Access Initiative. This is the core team, but we are actually a bigger team, but this is the team that confounded prisons. We bring experience from the Canadian Pediatric Society, and so we have Professor Nalini and Professor Doug that have been instrumental in making sure that the algorithms are tested very well. Dr. Deta is a pediatrician who informs most of the things that we include in the technology. Myself and Dr. Francis, who is an epidemiologist, who has designed all the studies for testing this technology. And so every dollar that we get will go a long way towards improving lives of newborns in this country and beyond. Thank you.
Okay, thank you very much. Just to introduce myself again, I'm Dennis Nwagawa. I work with the TPO Uganda. This is going to be the outline of my presentation. I'll give a brief background and describe the activity of the project. Then I'll dive into the data-driven methodology, then give results, conclusions, and takeaway messages. We all know that Uganda has made very tremendous progress in the fight against HIV/AIDS. But you realize that retention, testing, retention, and care, and viral load suppression among children is still a challenge when you compare this to the adults. The recent available data that I could land on shows that at 62%, Uganda national viral load suppression rate among children and adolescents living with HIV/AIDS lags well behind the 92 rate for adults. So this calls the innovators in the room, what can we do to ensure that children can and adolescents can move up in terms of the care for HIV. Just a brief about the project that I'm going to present. It's called USAID Keeping Children Healthy and Safe Activity, KCHS. It is a 5-year funded project, started 2020 and is ending 2025. And it's implemented in a consortium with TPO Uganda as a prime. And all those partners are called Avis Repsi and Masaka Diocese as the subs. And we are currently working in 25 districts in central and southwestern Uganda. And the purpose or the aim of the project is to prevent new HIV infections, but at the same time ensure that the children, adolescents, and adults know their status and they are enrolled on treatment and they are virally suppressing. This is the goal, as I've already said, but we have objectives, which is one is economically empower the vulnerable children and the adolescents and their families to access core services, but also we are looking at empowering or strengthening local government platforms as well as community platforms, and also improving continuum of care. It is a $19 million USA project, and we target children and adolescents living with HIV/AIDS, HIV/AIDS exposed infants, children of female sex workers, pregnant adolescents, and their caregivers. This is just an outline of what we do under each of the 95s. And as you realize, under the first 95, we ensure that we identify the children who are at risk and ensure that we link them to testing services. Then on the second 95, we ensure that we link them to care, and then ensure that they are enrolled on treatment. Then on the third 95, we make sure that we follow up, tracking, ensuring that there's adherence, counseling, and ensuring that the appointments are followed, and then intensify the linkage with beneficiaries to differentiated service delivery models. Then the project, as I said earlier, as an OVC partner, we use a collaborative approach. So those are the clinical partners and the health facilities that we work with, regional referral hospitals, and we sign MOUs. Our work is based on MOUs. As I said, at the initiation, there are things we do at the entry, and that is working on the activity monitoring and evaluation and learning plan, which provides us the guidance of implementation. Then we identify we get the targets, then we negotiate and sign MOUs, and then we also identify and place case workers at high volume facilities. Then through implementation, as a data-guided activity. We support enrollment of beneficiaries and provide literacy education and track viral load suppression, ensuring that we have very up-to-date data. Then, as we realize, we have taken advantage of the social media to share on time the data to be able to address the suppression barriers and any challenges. Those are the commonly platforms we have used: Microsoft Teams, Google, Zoom, and WhatsApp. We have our staff, we have created different WhatsApp groups, and from where we share information, training, data, and so on. In brief, the KCHS activity is on track towards achieving the 95-95 goals. For example, on the first 95, we are actually at 84%. Then the second 95, we are at 100%, whereby all those who are being tested are on treatment. And on the third 95, we are at 96.6%. This is how we are, in terms of the OVC served per district, we are above 100%. In other words, we are being able to use data to ensure that it guides us to ensure that all that we target are on treatment. So that's the beauty of using data. Again, this is the distribution through the quarters on how we have been progressing. In the quarter 4, that ended in October 2022, this year, we are at 100.1%. Through working with health facilities, we have built a very strong connection or linkage with health workers. And here is one of the doctors at Kawa Regional Referral Hospitals. She has appreciated that because of working together and using data, she's able to help her clients to adhere. And that is a very, very strong statement, because previously there was limited connection of health workers getting to the facility, to the communities, but we have activities where we have to go with them. Okay? Okay, in conclusion, to attain 95-95 epidemic control goals, is important for OVC mechanisms to work with health facilities and clinical partners. Then placement of case workers at health facilities who support in documentation, client appointments management, bidirectional linkages, and follow-up of clients for better treatment is a game changer. So whatever we do, we need to build strong linkages between health facilities and communities. And still working with the clinical partners to triangulate data, making evidence-based decisions is very, very, very critical if we are to reach 95-95 goals. COVID has taught us that we need to really work with and tap onto the technology. Thank you so much. Acknowledgement to all those partners displayed. Thank you very much.
All right, thank you. Good morning. I'm called I'm called Dr. Nelson Tunamasko. I happen to work with Makerere Institute, and part of the Ulira app that I'm going to present about. And I as well happen to lead a health systems think tank. That's a new organization on the block that tries to tackle problems related to the health systems of Uganda. And I lead the research department for that organization. Maybe there are some things that I'm going to be mentioning, and I want to first define them. The first is called hearing loss. For us to say that someone has hearing loss, we say this person, the hearing threshold should be above 20 decibels. Yeah? And WHO normally grades this hearing loss into 4. We have the mild, moderate, severe, and very profound. For the people that you normally see using sign languages, for those ones that are the extreme end, and we call them, they have profound hearing loss. And for this one, it's always above 81 decibels. Close to 500 million people suffer from hearing loss. And this is expected to rise to over 630 million people by 2030. And most of this hearing loss is contributed by noise, called noise-induced hearing loss. And this is explainable because of the increase of the industrial revolution, yeah? Industries produce a lot of noise, and the people that actually work in these industries are exposed that they have a risk of getting occupational hearing loss. And as a result of that industrial revolution, occupational hearing loss is increasingly becoming a serious health problem. The WHO epidemiological data says that occupational hearing loss currently stands at 17% to 48%. That is the epidemiological prevalence of occupational hearing loss. And occupational hearing loss currently ranks among the leading causes of occupational illness, yeah, and is responsible for over 46 million years lived with disability. In Uganda, in 2019, Ministry of Health carried out a survey, and it found out that over 2 million people suffer a degree of hearing loss, and 11% of this is in the working population. The most contributing population were those that work in noise areas, especially manufacturing industries. So we set out this study for WIRA app in order it can assess hearing loss among the most at-risk population, and that is the workers in metal industries. Maybe a brief about WIRA app. WIRA app was made in 2018, and it has since done several studies that confirm its usability, and it has been shown that it has a high sensitivity and high specificity in hearing loss screening. And it was compared with the standard, the pure tone audiometry, and it showed to have a high specificity and sensitivity. So we set up this study to determine the prevalence of occupational hearing loss and acceptability of using the WIRA app to assess hearing loss among workers in a steel and iron manufacturing industry in Kampala, Uganda. And this was a cross-sectional study where we did the qualitative and the quantitative methods of data collection in one of the metal manufacturing industry in Kampala. We retrieved a list of employees in that industry, and then randomly selected 354 participants into that study. The participants, we gave them a pre-tested interviewer guided questionnaire, and then undertook hearing loss screening test using the WIRA app. We as well did FGDs and in-depth interviews to confirm the acceptability of using this app. That's the statistical analysis. Some of the results that we got from this study, over 94.1% were males, and of which their age was the median age was 27. And majority of them were machine operators, of which the risk factors that we assessed included history of smoking and the number of years that someone had worked in that industry. The graphs that you see there, one is a participant with normal hearing loss, with normal hearing, and then the other one is a graph that is produced in case someone has occupational hearing. And this is produced by the Wira app. So overall, among the population that we studied, we found that the prevalence of hearing loss was 11.3%, meaning that of every 100 people that would assess with our Wira app, 11 of them would be having hearing loss. And the graph that you see there, it is comparing between the perceived hearing loss when you ask them, do you think you have hearing loss? And then after measuring them, the graph here shows that indeed you may say that you don't have hearing loss, but when we screen with your Wira app, it shows that you have hearing loss. Another most important thing that our Wira app does is that mostly hearing loss is mostly in the old population. So there's a concept called the notch that was introduced to assess whether any measurement tool distinguishes between the cause is either age-related or occupational health-related. And our result showed that less than 5% of the participants had a notch, meaning that these participants indeed had hearing loss, related to occupational hearing, rather than being contributed to age alone. And this is what we got from our qualitative data, of which the study was published with +1. However, one of the most quotable notes that we got from the participants include that with the Wira app, I think I'll be able to do frequent screening to determine my hearing performance, because with this app, I don't have to see a doctor. I can do it anytime. And this confirms our overall result for that acceptability, which shows that Wira app was indeed acceptable to be used among the industrial workers. So what are our conclusions for that study? Occupational hearing loss was highly prevalent among industrial workers, and from the qualitative aspect, Wira app could be an acceptable, cost-effective, and easy-to-use tool. However, challenges such as technology literacy and lack of smartphones could hinder the uptake of this of the Wira app. However, we made recommendations from that study. We thought there is a need to strengthen noise reduction measures in industries, notably one the Occupation Health Act that was enacted in 2016 says that all employers should actually ideally screen their workers that work in industries that are exposed to noise. However, this is not followed by these employers, and we encourage that they should be strengthening of screening of these particular workers. Given that we have such tools, this is very possible. And we should as well be informing the high-risk group, especially now this we did on industrial workers, on the incidence of carrying out regular hearing loss screening, such that this can be caught early, prevented, and treated before we go to that stage of profound that I started with. Those are some of the peaks. The first peak here is the interface of the Wira app. Then the next peak there is a study that was validating the Wira app. We did it among TB patients that confirmed the high specificity and sensitivity of using this app. And the last peak is where we were presenting at the World Health Summit, which took up this innovation. I would like to thank Makerere Research and Innovation Fund that helped to fund this study, and plus the Wira team, which is here. And we want to scale up this particular innovation where we want to put it to the community healthcare workers, such that they can be able to screen the highly prevalent or the most high risk population. For example, the builders, the DJs, such that they can get this hearing loss at an early age.
Good morning, everyone. I'm Elinor Manyanda. I'm presenting this study. I work as a health economist with IDI. I did this work together with Professor Joseph Gumira at the University of Washington and Professor Michael Sivanson at the University of Gothenburg. That is my master thesis. As a background, meeting the unmet need for contraception is beneficial to Uganda. It averts 76,000 annual maternal death and saves around $8 billion in cost of unintended pregnancies and saves around $7 billion on child care and maternal care. Even then, several contraception interventions have been innovative and proven to be cost-effective. Economic evaluation is the comparative analysis of two or more interventions in terms of their costs and benefits. And in Uganda, we've had several interventions that have been cost-effective, yet none of them was incentive-based, which leads to the objective of this study, to assess the one-year cost-effectiveness of using an incentive-based family planning benefits card to increase access to modern contraception among young women in slums of Kampala, Uganda, compared to the status quo situation, which is the standard of care. And in methods, this was a model-based cost-effectiveness analysis, and we used data from the one-year retrospective impact evaluation of the FBC intervention, which was quasi-experimental in nature, and additional data was obtained from the literature. The study population were young female adults aged 18 to 30 years, non-users of modern contraception, sexually active and not pregnant, also not willing to give informed consent. That is a picture of chifombirazone in Kamocha. And like I said, the setting was chifombirazone Kamocha, that is for the intervention, and the standard of care, or the comparator was Karere urban slum, which is downside Kampala. And these two slums have similar characteristics. Most of the people are unemployed, they are under the low socio-economic class and have high unmet need for modern contraception at 30%. And this is the FBC. It allowed young adults aged 18 to 30 years to pick any family planning intervention of their choice at our partner clinics. And these methods include male and female condoms, implants, IUDs, injections, emergency pills, counseling and guidance, pregnancy and HIV testing. And this was done in partnership with IML insurance company, as well as locally based partner clinics and community health workers. The comparator is an out-of-pocket venture where someone walks straight to the clinic and asks for the intervention they want. And predominantly urban centers only have private centers, and their prices are 4 times higher than public entities, yet the largest population lives on less than $1 per day. And the study perspective, we did this study from the modified societal perspective, whereby we don't do anything as recommended, but we try as much as possible to ensure that everything is within the economic perspective. And also as the Ministry of Health perspective, all costs were included, and we did this year on a time horizon of 1 year. And the main outcomes, we used a decision tree model whereby the main outcome was the probability of unintended conception and the incremental cost effectiveness ratio in terms of unintended pregnancy per averted. And that is how we measured costs. And we did this in 2022 US dollars. The main results, these are the best case inputs we used to model this up. And the main outcomes, we see that the absolute cost from the societal perspective was $195, and from the provider perspective, it was $193. This leads to the probability of conception was 0.2 in the FPBC compared to 0.4 in the standard of care, leading to an incremental cost of $31 and $30. And the main outcome, which is the incremental cost effectiveness ratio, the ISA per unintended pregnancy averted, was $125 per pregnancy averted and $121 per pregnancy averted from the societal and provider perspective. And what is the interpretation of this? At an extra cost of $31, we see that the FPBC, or the Family Planning Benefits Card, averted 0.24 chances of unintended pregnancy compared to the standard of care from the societal perspective, and also did this at an extra cost of $30 from the provider perspective. And we also did the sensitivity analysis to see if our results were strong enough to maybe to be generalized. And we did this through the one-way sensitivity analysis. And from this tornado diagram, we see that our results were mainly driven by direct medical costs, possibly due to high personnel and program costs, as well as direct non-medical costs. Then from the cost effectiveness trend, we see that the largest pairs of incremental costs and incremental averted pregnancies were aligned in the northeast and southeastern quadrants of the trend, which means that we are certain that the FPC indeed was viable and is cost effective. We also drew the cost effectiveness acceptability curve, which also confirmed that at almost 100% of all iterations, the FPBC was still cost effective compared to the standard of care. And when results lie in the northeast and southeast quadrant, you do further analysis in economic evaluation. And we calculated the incremental net monetary benefit, which was positive in nature, in confirming that indeed the FPBC was cost effective compared to the standard of care, as well as the expected value of perfect information, EVPI, showing us the amount of money needed for researchers to see why the FPBC indeed was cost effective. And this was $755 per person. In conclusion, the FPBC is a highly cost-effective strategy in increasing access to modern contraception among young women compared to the standard of care in a low-income setting. It can even get certainly low and cheaper due to low marginal costs of adding more people on the program. That is because it was conceptually similar to an insurance program which thrives on the rule of large numbers. And in order to achieve 5 out of 17 2030 SDGs, the FPBC would be indeed ineligible for use. And way forward, this manuscript has been accepted for publication in the Journal of Contraception and Reproductive Medicine. And I thank my colleagues, Joseph Barugumira and Michael Swanson, to put this together. I thank you for your attention and interest.